Hi guys, after a long time I'm back with another video. Yeah, so I think my face is not very visible because of this light over here. So I'm gonna put my camera like this. So after a long time, just before the new year starts, I'm gonna be taking up a very short topic on interpretation of endometrial biopsies. And we've done a lot of hemat this year. I'll also be doing a bit of histopathology in between my mostly my hemat lectures, and I hope it is beneficial and helpful to you. My face might not be very visible, but at least the slides are. So very quickly, yeah. So see, endometrial biopsies. Let me tell you, the latest WHO has divided the endometrial carcinomas into various forms, but the most common ones are the endometrioid and the serous types. That is the type 1 and the type 2. And while I was doing my MD, in the recent advances, they had introduced the presence of molecular mutations in endometrial carcinomas as important prognostic factors. Now, the WHO is dividing the endometrial carcinomas as per their molecular mutations. So, that is where the role of molecular pathology comes in oncology. And now you also have to see whether these mutations are there or not in the endometrial carcinomas to grade something as, under that heading. So, in the histopathology of endometrial cancers, if we all know the endometrioid are the ones which occur in the younger age, are more responsive to therapy, occur in the premenopausal, like not the perimenopausal, but the fertile period of the age, and they have three grades, grade 1, 2, and 3, and that depends on the kind of endometrial glands you see. The number of gland pattern you are seeing, say 40 to 50%, it is a grade 1 or 2 tumor. The solid pattern, if it becomes more than 50%, it becomes a grade 3 tumor. So this is what this image is going to show you. So this shows irregular glands. So if you go back to your MD classes, we used to see the loss of polarity of the lining epithelium, the hyperchromasia, the pleomorphism, presence of mitotic figures, and the lining of the gland being irregular. Back to back arrangement of glands with no stroma in between. These are some findings which point towards a carcinoma versus a benign lesion. So here it shows, the first image over here is showing irregular glands which are lined by pseudostratified columnar epithelium with mild cytological atypia, and it is less than, there is almost no solid area. Fine. So this is a grade 1. Grade 2, that is this image, the tumor contains 6 to 50%. By solid area means this: there is a gland, then there is no gland, here there is no gland, here there is no gland, and then there is gland. So the glands fusing and forming a sheet, that is solid area. And as you go higher grade, you see there is diffuse loss of glandular pattern. So this is what the endometrioid carcinoma grading looks like. Fine. Serous carcinoma has a lot of clear cytoplasm, as if there's cytoplasmic vacuolation, and that is why the word serous carcinoma comes into the picture. And then, of course, we also do some MSH6 immunocytochemistry, immunohistochemistry, and we document the loss or the presence of that. However, as per the new WHO, I will show you pole P53, WT1, these are the more important ones. So how does the latest WHO classify? So for your exam, this is important. I mean, if you make this table, you will get good marks. So endometrial carcinoma, we go for a pole mutation. Pole, if present, that is, this comes through NGS, pathogenic or wild type. All right. So for some of these markers, you have IHC also available. You have some, for some of them you have fish also available. But pathogenic or variants of uncertain significance, these terminologies are used when you're doing an NGS. So endometrial carcinoma, if it is mutated for pole, then we just call it a pole mutant EC and direct surgery, no adjuvant chemotherapy. If it is a wild type means not mutated, then we go for MMR studies. You saw MSH6 in the previous image. We have to see whether it is retained or lost. If it is a deficient tumor, then it is an MMR deficient EC. Here we do a PDL1 inhibitor and give radiation therapy. If the pole is also okay, there is no pole pathogenicity. If the MMR is also fine, then you go for P53. P53 mutant type of you give, it is labeled as a P53 mutant, give chemo and targeted therapy. P53 wild type, then you label it into some other non LSMP category, that is no specific molecular profile, and then you give radiation and hormones. So they are, you have to go for pole, you have to go for MMR, you have to go for P53, and then only can you differentiate it into whether wild type or mutated. So this is an important table to remember. Biopsies like this, please don't report gland within gland strips. Here you might label this as stratification. No, please, these are superficial strips, no stroma. This is inadequate for reporting. Any pattern here, please don't report it. Okay. So how do you approach an endometrial biopsy? Either you get a biopsy where there is no endometrial tissue. A lot of times we just get cervical tissue. Then you need to report it as inadequate sampling. Go for radiology and a rebiopsy. Superficial strips, as I showed you, if the ultrasound is normal, you can just report as unaccessible, or we just report what we are seeing in those superficial biopsies as a note, and you can just say do a follow-up, radiological follow-up, if and do a repeat biopsy only if there is some abnormality on the ultrasound. Otherwise, leave the patient. Of course, if it is an intact, good specimen, then you have to give your report. So I have used some examples here, like see, this is known as telescoping, gland within gland. Fine. This is normal. This is not proliferation. Some people call it an indicator of proliferation. No, it is not. It is just how your section has been cut. So please don't, this is telescoping. So please don't report it as proliferation. It is artifact. This kind of picture where you can see glands which are back to back and curved, and you know I'm calling it a compression artifact, but this can cause a lot of confusion, where you have to see a complex hyperplasia or a hyperplasia with atypia. So my advice to you is, when you get this area, don't just ignore it as an artifact. I know it is written here as compression artifact because the author knows this is a compression artifact for this journal. But when you get a slide like this, do not just leave it at compression artifact. Get deeper sections done. If it is just an artifact in the deeper section, you will start seeing some space in between these. But if it is not, you can give a note that focal area shows back-to-back arrangement of benign looking epithelium. Here you see the epithelium is monolayered. There is otherwise no problem. Hence, clinical correlation is advised. But just do not ignore this completely, but do not overdiagnose it also. So this, I will cite this paper in the end. They have given a lot about compression artifacts, etc. Then they speak about endometritis, and we all know we have to see plasma cells in the stroma to call anything endometritis. You see a polymorph, it could be a breakdown endometrium. It is there. It is not endometritis until unless you do not see plasma cells. So, a variant of endometritis termed as focal necrotizing endometritis has been described, characterized by lymphocytes, histiocytes, plasma cells, and neutrophils. There can be granulomatous endometritis of tuberculosis. So this, they have given types of endometritis, but do remember, anything else, first look for plasma cells, these cells. And if they are not there, then refrain from calling anything as endometritis. Then see, these are endometrial glands and all this is squamous. Now you might consider this a SCC. Now you will get a squamous epithelium in two situations. Either you have taken out ectocervix only, or there is squamous metaplasia of endometrium that can occur in older individuals also. Squamous morules in an otherwise normal endometrium is a benign finding. However, my seniors used to tell me that if you are getting any form of metaplasia in the endometrium in the sample received, write a radiological correlation and go for deeper sections, because you might have an area of an endometrial in situ carcinoma or dysplasia somewhere. So A florid squamous metaplasia like this, please don't report it as a carcinoma, but always give a caution line for radiological correlation and follow up. Right. Then of course there can be florid papillary hyperplasia like this with nuclear atypia, which you can see over here, and this mimics serous carcinoma. So yes, you cannot totally rule out sometimes a benign endometrium, and that is where the role of immunohistochemistry comes, the role of radiology comes, and role of hormonal exposure comes. Okay. So this is an endometrioid carcinoma from the, see, this is a biopsy from the surface of the endometrioid carcinoma. Now, if you see this, what you see are cystic spaces lined by this epithelium. So what they want to show you is microglandular adenosis of cervix looks just like this. Now you might get overconfident and diagnose it like that because you find the nucleus to be almost fine. But no, this is actually an endometrioid carcinoma. So the importance of deeper sections. So you'll ask me, so then how am I to say whether it's a carcinoma or not? So my approach to such cases is, when I'm in doubt that this might not be, I give a say, if I'm favoring a carcinoma over a benign process, but I'm not sure, then I write this in my report that I favor a carcinomatous process over a benign process. However, deeper section, more representative biopsy, radiological correlation, or whatever I need to give, I do give the surgeon a direction. I don't leave it to as refer description or I cannot conclude. There is something that you are concluding, you are just not sure. In the previous case also, where you saw that papillary hyperplasias looking very I would, if supposing I am not very well trained and I find that to be carcinomatous, I would write I favor a carcinomatous process over a benign process. However, in view of then what are your whatever your confusing point is, a correlation, a deeper biopsy, and a hormonal profile, or whatever you need to advise is recommended. My advice to is always and always conclude your report. Please don't leave it to the surgeons or the physicians understanding. They are not the pathologists, you are. Okay. Again here you see, now you see this kind of very dark blue color with palisading. This is how an atypical gland looks. Fine. So when I see this, then I become more alert, rather, so this kind of pencillate dysplasia, rather than when I was showing you the crowding before this, where the cytoplasm was ample. So here also the cytoplasm is ample, but see, the nucleus is becoming very pleomorphic. To me, a more striking feature of dysplasia is this kind of a nucleus, and you will get this somewhere. Fine. So in a gland which is in a specimen where you are getting dysplastic epithelium, so this is going to become dysplastic, and this has totally become dysplastic. So this is an atypical gland. So here they are just telling you about the adenocarcinoma with increased stromal cellularity and mitotic activity just beneath the endometrial layer. This is known as the cambium layer. It's alright, just an image in the article, that is why I shared it with you. See, now if you see, this is a serous carcinoma, and look at the nucleus, and it has a very prominent nucleoli, and you're going to see it almost everywhere. This kind of hobnailing, this is very particular of serous carcinoma. Over here also you can see some hobnailing over here. So when you see such a level of atypia, and this is not area stellar reaction, this is what you can be confused with. So area stellar reaction will show you a lot of stromal decidualization, and in that you will get this, and of course that happens in pregnancy. So you will be having history of pregnancy. This tumor is more of an older age tumor, and hence you see they have done a P53 IHC, where the atrophic residual glands are not showing it, the tumor might be showing it. So see, P16 and P53. So P50 wild type is and P53 mutated. So we have to see whether the expression in both P16 and P53, the expression is continuous or heterogeneous. Heterogeneous means normal. Continuous or loss sometimes means malignancy. Since these are normal markers of the body, you and I have P53, P16 also we have, so their mutation will lead to some sort of change in their expression, either loss or too strong an expression. Otherwise they are heterogeneously present. These are cell cycle regulators. They are not mutated proteins. They become mutated because of something, but they are naturally present in the body, as compared to acquisition maybe of some protein which is due to a virus like HPV. If I take P16 is a cell cycle inhibitor which gets mutated by an HPV. But if I acquire a protein which is normally not there in my body, then that mostly comes out, or is a marker of tissue. Supposing I go for a leiomyosarc and then you say SMA, smooth muscle actin. Smooth muscle actin is normally present, but leiomyosarcoma is a tumor originating from the smooth muscle. So उसमें उसका expression बढ़ जाएगा. ठीक है. P53 और वो क्या है, वो सिर्फ एक सरफेस प्रोटीन है जो ये बताता है कि ये स्मूथ मसल है. P53 P16 क्या है, सेल के ग्रोथ को रेगुलेट करने वाले मार्कर्स है. इनके म्यूटेशन से या तो इनका एक्सप्रेशन घट सकता है या बढ़ सकता है. तो तो हमें ये पता होना चाहिए, वी नीड टू नो व्हाट काइंड ऑफ IHC आर वी इंटरप्रेटिंग टू एक्चुअली इंटरप्रेट इट. देयर आर सर्टेन IHCs which are interpreted as positive when they are lost. They are naturally retained in the body, but when they are mutated, they are lost. There are certain IHCs, most of them, which are interpreted as positive when they are present in the tissue. And then there are certain IHCs, like the one I am telling you about, which are interpreted or based on their percentage of distribution in the cells. Okay, because not all cells can be in dividing phase at one point of time. That is why P16 and P53 is heterogeneous. But when it is mutated, it can be completely lost or very strong. Means all cells in the same phase, which is not possible in a normal body. Okay. So this is an endometrioid carcinoma. Serous say you can differentiate a more well-formed gland. This looks like a solid area or a squamoid area, if I might say so. Okay, and that is why I said if you get a squamous module, go for deeper sections, look for radiology, and then rule out malignancy in a biopsy. So this is the paper. Please, I have just touched some points. See, they have talked about pill endometrium and hormonal changes. Or when you label something as a disordered endometrial proliferation, that is a precursor to hyperplasia, then atypia, then so disordered has approximately 10% cystic changes in the gland and telescoping and some focal area of back to back or hyperplasia. Pill endometrium will show you a lot of gland breakdown, stromal breakdown, maybe no telescoping and less than 10% cystic area. If you're taking a lot of progesterone, the stroma might show you a lot of deciduoid changes. If you are a pregnant, it's a pregnant endometrium, you might get an Ariostellar reaction. You might get products of conception. So you really need to be, and of course, I'm not taking that today, endometrial dating. If you are on, you have a menstrual phase, and then at what phase do you take? For instance, for polyps, if you have an endometrial polyp, we prefer looking at the polyp, after the progesteronic phase has gone, when the endometrium is at the thinnest, to see the actual thickness of the polyp, because they say proliferative endometrium might hide the polyp inside it, or a progesteronic endometrium might not actually show how big a polyp is. So once everything is shed, the polyp will stay. So the actual size of polyp can be determined by a transvaginal sonography after in that phase, just after you've had your menses. Okay, so we that is part of endometrial dating. So that I'm not taking right now. Most of you have done it in your physiology. All of you have done it in your physiology. I will take it if it is required. My thing is, when you interpret an endometrium, never interpret a superficial biopsy. Never ever. Do not interpret an endometrium in absence of hormonal history, age, and pregnancy. If you have doubts, please do not leave it at refer description. Write whatever you feel like. Write a note why that may be wrong and what needs to be done. Do not leave it at surgeons, or the gynec's mercy. They are not the pathologists. They don't know why what is confusing you. Always look for viral inclusions, IUD changes. These are very, very common things that you find. Women, do not call something endometritis until unless you see a plasma cell. If you get a granuloma, of course, things are different. Looking at a poly, do not label anything as endometritis. Polys can come during menses also. A lot of hemorrhage can be there in menses. Then serous carcinomas can mimic progesteronic influence. You have to be very careful. If you might get just endocervix or ectocervix, again you have to be very careful when you are examining the endometrium. These are some few points. Rest, if you go through this article, it's a very good article and this will be very helpful to you. So happy new year in advance to everyone, and I hope this lecture helps you a bit in interpreting the endometrial biopsies. Thank you.